Good evening to all of you. My name is Narendra Chokse and I represent Torrent Pharma. I am your host for the day. On behalf of Classic Cardio Academy International, I welcome you all to the day 2 of CCA webinar. Yesterday we discussed updates from ACC 2021 conference with Dr. Greg W. Stone. Today the topic is updates from EuroPCR 2021 conference. For presentation and discussion, I welcome our esteemed faculty members who are with us today. We have with us Professor Dr. Sadanand Shetty, co-founder of CCAI International, Director, Department of Cardiology, Somaiya Super Specialty Hospital, Emeritus Professor, Dr. D.Y. Patil University, New Bombay, and he is also President, Cardiology Society of India, Mumbai. He is a fellow of ACC and ESC. We also have with us Dr. V.T. Shah, co-founder of CCA. He is senior interventional cardiologist at SL Raheja Fortis Hospital, Sefi Hospital, and Surana Hospital, Mumbai. I also welcome our esteemed guest speaker, Dr. Carlos Di Mario. Dr. Di Mario is an interventional cardiologist. He is professor of cardiology at the University of Florence and director, cardiology division of Careggi University Hospital, Florence, Italy. So once again, welcome Dr. Di Mario. We also have on our esteemed panel, Dr. Mahesh Fulwani, who is interventional cardiologist from Nagpur. We have Dr. Ravinder Singh Rao, who is interventional cardiologist from Jaipur. We have with us Dr. Ajit Mullasari, who is interventional cardiologist from Chennai. And we also have with us Dr. Balbir Singh, interventional cardiologist from Gurgaon. And I'm sure this unique platform where evidence meets experience will help all of us to enrich our knowledge. If you have any questions to ask, please use the chat option and send it to the moderator. And I welcome all of you again, and I request Dr. Sadanand Shetty to take the proceedings further. Dr. Shetty, please.
Thank you, Narendra and Torrent Pharma for giving us this very unique opportunity to have this webinar. As Narendra mentioned, yesterday we had update of ACC 2021, and today we have planned EuroPCR update. And my special welcome on behalf of CCAI, Dr. Mario, Dr. Indian faculties, Dr. Ajit Mullasari, Dr. Balbir Singh, Dr. Ravinder Singh Rao, and Dr. Mahesh Fulwani. And I was told Dr. Mario is busy in some emergency. So what we will do, Dr. V.T. Shah is going to start the presentation. And then till the time he joins, we faculties from India, we will discuss the cases. With this brief introduction, I would hand over the proceeding to Dr. V.T. Shah. V.T. Shah.
Okay. So good evening, everybody. Thank you, Dr. Sadanand Shetty and Torrent Pharmaceuticals to give us this opportunity back to back to discuss the late breaking trials and other important updates. Yesterday we had ACC 21 with Dr. Greg Stone, and today we have EuroPCR 2021 with Dr. Carlo Di Mario. So friends, he is busy in an emergency and said he will join shortly. In the meantime, we will discuss one or two trials which are relevant today. So let me go through. Okay. This is not Rahul. Yeah. Okay. Yeah. So what I'm going to do is I have a few structural heart disease and few coronary. And we have with us people who have experience in that. So I'm going to take you through this series of trials one by one. And the format would be that I would present some few slides on that trial or study which was presented in EuroPCR now, a couple of days back. and then ask the comments and questions regarding this on the same trial. So one after one, we will go forward. So I will share and stop share and so on. So now we'll go with the first trial. Now this is percutaneous edge-to-edge repair. We know about mitral valve, percutaneous, we know about aortic valve. So this will be about tricuspid valve. And I'm sure Dr. Rao also would have his experience and comments on this. So this is a 2-year outcome, although what is happening? Yeah. So this is management of too many things coming in the way.
It's actually 2 slides which came, sir. Just go back 1 slide, I think.
Yeah. So I got it. So this is management of patients with tricuspid regurgitation is complex with limited indications for surgical intervention and medical therapy. The TriClip tricuspid valve repair system was CE marked based on triluminate trial conducted at 21 sites in Europe and USA. So this is regarding initiated to evaluate the safety and performance of the TriClip tricuspid valve repair system for the treatment of symptomatic TR. The 2-year clinical outcomes, including TR severity, safety, and quality of life outcomes, will be presented for the first time. So almost like 62 and 23, 85% did have a change in the grade of TR. Okay, and about 15% did not have any change. So TR reduced to moderate or less at 30 days, and which was sustained for 2 years follow-up. So 60% had definite improvement in their grades of TR. And the sustained improvement in NOHA class and 6-minute walk test were evident over the course of 2 years, as you see here. Okay, and sustained improvements in the quality of life improvement scores. So a significant reduction in hospitalization rate, which was much more than the grades of TR. So more than 50% of the people had significant reduction in repeat hospitalization. The overall mortality rate was 18.7% at 2 years, but this was definitely less than the medical management group. So TR reduction that was achieved at 30 days was sustained through 2 years. Improvement in functional status and quality of life was sustained through 2 years. And overall reduction in hospitalization rate post-procedure was observed compared to the rates prior to the procedure. All-cause mortality remained low at 2 years. This is the first report of 2-year outcomes for tricuspid transcatheter edge-to-edge repair with the TriClip TVRS. TR reduction with the TriClip device and the corresponding improvement in functional capacity and quality of life was sustained through 2 years follow-up. TriClip TVRS may offer a safe and effective alternate to surgery in this high group population. This is not a large-scale study. 58 patients from 21 centers appears to be a promising technology, and selection of patients versus we have a trick valve also. So let us hear from our experts what do you have to say between selection between these two valves and of course long-term experience of them. So I'll stop share here just now and have comments from Dr. Rao, Dr. Mulasari, Dr. Balbir Singh.
So,
I think Dr. Mahesh just joined, I think. Welcome, Dr. Mahesh. Yeah, Ravinder, you can carry
Mahesh,
on.
yeah, fine.
Yeah.
So that was a good trial. So let me tell you, sir, the problem with tricuspid valve, it's like a no man's land. Even in our country, a lot of patients, we see a lot of young patients who would have undergone mitral valve replacement, but the tricuspid is left as it is. Now, coming back to the therapy, definitely the tricuspid valve repair therapy is better than a replacement therapy because on the right side, the valve thrombose faster, the patients need to be on anticoagulation. Now, remember the tricuspid valve is different from mitral valve. Mitral valve is a bicuspid valve. We understand the anatomy very well. The mitral clip, we know where to implant. In the tricuspid valve, there is a septal leaflet, anterior leaflet, and a posterior leaflet. and the anatomy, the echo findings, all those things are a little bit more complicated. So if you ask me, I don't have any experience of using a TriClip. All my experience is of trick valve. So I always say the trick valve cannot replace a TriClip. The trick valve is more of a compassionate ground. So use it for compassion. The tricuspid regurgitation is still there. We are able to protect the visceral circulation from the effects of tricuspid regurgitation. We might decrease the dose of diuretics, but we don't know the long-term effects of its enlargement on RA and RV. Now, I think TriClip is a promising therapy. All we have to learn going forward is probably how much of 3R reduction will make a clinical difference. So you see, this was only 1 grade reduction in TR. Probably a 2 grade reduction in TR or a 3 grade reduction in TR with no increase in the gradients would make more clinical betterment. So I think we all are learning in this. But your question was trick valve versus TriClip. I think we need more data on this, but definitely intervention at the level of tricuspid annulus will make a difference and will give better results compared to a cable valve system where we are implanting into the IVC-RA junction and SVC-RA junction.
Right. So the trick valve is the one which you have to implant at the junction and see. But as you said, that it is just on compassionate grounds,
Yes.
right?
Yes.
Yeah. And the cost of that valve, trick valve, is around,
it's
expensive.
It's expensive, sir. So, very few cases, and I would tell them that this is not the treatment. We might decrease the dose of diuretics. No. It recently got CE approved. Earlier, it was not even approved. I mean, just I believe a week ago or so, the valve was CE approved. But we have to understand that it is an heterotopic implantation of a valve, tricuspid valve. We're trying to implant in the IVC and SVC-RA junction. So TR still remains. The RA-RV will still keep enlarging. Its long-term effect is not known. The RV enlargement might affect the septum and the LV loading, unloading. Similarly, might happen on the septal side also. So definitely a valve.
But can we use it in rheumatic also? Rheumatic?
Yes, sir. So again, as I said, it's a compassionate. So you're talking about TriClip for rheumatic or
both? Both. Comment on both.
So I would like to comment only on trick valve, sir. Trick valve can be used for rheumatic because you are not even touching the tricuspid valve. You are implanting in the SVC-RA junction.
Right.
TriClip, sir, I have zero experience or knowledge, but as of now in the trials, no rheumatic patients are enrolled.
So Ajit or Balbir, anything?
So Dr. Shad, let's go back to our history. So the surgeons have been doing tricuspid valve repair for a long period of time, and the results have not been very great. Why? Because the annulus is too big, the annulus gets dilated, the RV gets dilated, and it's a tricuspid valve. So where to repair? So the surgeons have been trying desperately for several years, and I know the results have not been optimal. So it is not going to be a great success with large number of patients that we have. Rheumatic is going to be a disaster, of course. And this trick valve is non-physiological valve. I mean, it's a compromise. It's a compromise that you reduce the load going to the jugular vein or the hepatic vein by just putting two valves, one in the SVC and one in the IVC. It doesn't. The RA keeps dilating, the RV keeps dilating. The outcome is going to be dismal in the long term. So it's not a physiology that you're treating. So ultimate answer will come with a percutaneous tricuspid valve, which is going to be the final answer. These are not truly, in my opinion, the answers.
So, any comment? Sorry, you were saying, Ravinder, you wanted to say something?
But just one thing, sir, regarding sir said about the tricuspid valve repair, I totally agree, sir. If you look at the MitraClip history also, the Alfieri stitch never worked in the surgical population because it was a open heart surgery. You put the patient on a heart-lung machine. But the transcatheter Alfieri stitch is working because the side effects, the adverse effects of the surgery are taken care of. So I agree with you, sir. Probably a little more needs to be done in the tricuspid valve repair. Because in the right-sided and left-sided heart valves, the repair will last longer than a valve. But trick valve is definitely not an answer. It's a palliation.
Yeah, if you ask my comments, I would agree with what Balbir said. And, you know, we've worked with surgeons for the right-sided valve for a long time. And, you know, they're very hesitant, even in an aggressive surgical unit like ours, who does a lot of this stuff. But, you know, the tricuspid valve is usually repaired only usually at the time of the mitral valve replacement. Going isolated after that for the tricuspid valve repair, most surgeons hesitate. Unfortunately, tricuspid valve replacement is another disaster in the long term because the highest thrombosis of prosthetic valves is on the right side. So even with optimal INRs, you get into thrombosis. So next you're left with this tric valve, which I'm not very fascinated at all because I think it's completely unphysiological. In the RNR, we will keep dilating, no sense trying to protect the peripheral circulation when the heart itself goes down. And I think the IVS will get screwed in the whole thing, I think. And finally, the repair, tricuspid valve repair, I think we will need to learn a bit more. I'm not at all sure about this system, Ravinder. I'm not sure whether it mimics the mitral valve system or something else. And how do you clip a 3-valve leaflet when you have, you know, and how do you do it? I'm not clear at all. And how you grab these leaflets with 3 leaflets, how you clip it, I'm not sure. So, but end of the day, I think the 3 leaflets of different forms and, you know, septal leaflets being small and variant and so many other varieties happening, I'm not sure how the cardiologists will have that ability. So obviously it needs some polishing, the repair. And if that can be done without going on a pump and have good results like the clip on the mitral system, maybe yes, but I think it's too early. And this one level down result, you see, you know, I think is one issue which I've always suspected because I don't think it didn't even give too much advantage on the mitral. The other thing is, have you taken class 4 symptom patients or severe leaks? I'm not sure in this trial, it's mostly moderate. And, you know, just 2-year outcomes in a patient with moderate TR. We have so many patients with moderate TR who go wrong. And just based on symptom benefit to make a decision of 6-minute walk test, I won't jump at that conclusion on a patient. These are my comments on this.
Yeah, right. Rahul, can you stop sharing so that I can go on to my
No, just
slide?
1 minute, it is.
Yes, sir.
Just 1 minute.
No,
There
by
is
the
one
time
query.
you discuss, I think I will go to the slides because again it will take some time.
No, there is one question from Dr. Yash Lokandwala to
I'm
Dr.
showing that
Ravindra.
slide.
Okay. What is the actual mortality change, if any, with TriClip? Can we have the figures? And
So-
how much was the hospitalization reduction with TriClip?
So that's again, that is the question which I am myself asking from the trial, because if you see, as Ajit sir had pointed out, the data is not very robust. You know, 1 grade reduction, few meters increase in 6-minute walk test, some number decrease in mortality. Was it significant? So I think we all have to learn a lot about tricuspid valve and TriClip and anatomy. So I don't have the exact numbers, sir. Maybe I can go detail into the trial publication and send him the data that what was the actual mortality change.
Okay. So Rahul, can you stop sharing so that I can start sharing?
You can share now, sir.
Sir, just try, sir. You will be able to share, sir. Sharing is on, sir. Yes, sir. It has come. Right.
But yeah. Can you see?
Not yet.
We
Can
can
you see
see
my
your
slide?
web,
No?
sir. No, sir. We can
No,
see your web, sir. If you can open the presentation on the
I
bottom.
have already opened my presentation.
No.
Okay, I'll do that
I
now.
think you do the shares, screen sharing video.
Can you now? No.
Not yet, sir.
Okay. I just got what the problem could be. Yes, I share screen, then this, and now?
Sir, we are able to see the browser, sir. Just close the browser, sir. We just close this. Then hopefully the presentation will be visible.
No. today.
Ravinder, in the meantime, can I ask you a question? You've done patients with the trach valve. What have been your outcomes, Ravinder?
So, sir, I've done just 2 cases in past 5 years, and these were the 2 patients who came asking for it. So, one patient is doing extremely well. Actually, this patient, I did it in Jaslok, Mumbai. This patient had history of carcinoid syndrome, and the patient's tricuspid regurgitation, severe tricuspid regurgitation, patient was getting admitted again and again for right side heart failure. After the trach valve implantation, there was no heart failure admission. But so what I'm trying to understand in these patients is sometimes they are presenting very late. There is cardiac cirrhosis which has set in. I mean, we have to be very, very careful in selecting the patients. Sometimes they would be coming, after being in cardiac cirrhosis, gross ascites, malnutrition, albumin of 2. So I don't offer it to the patients. Let me be very frank. These were 2 people who went around on the internet, and then we had a written thing that this is only compassionate ground. But interestingly, 2 patients are doing very well. And the one I did in 2 of them, I did one in Jaipur, and that patient died at 9 months because of hospital admission, gross ascites. So I'm not a big fan of it, sir.
Yeah. So can you see the slide now?
Yeah. Carry on.
Yeah. So this says TR reduced by more than or equal to 1 grade in 85.4% of cases. And the severity, as you see here, baseline, and this is at 2 years. So this is severe regurgitation, and 21% here is massive, and 38% is torrential. So from this, at 2 years, it has become mild, moderate, and severe 38%. So that is it. And this is sustained improvement in NYHA class and 6 minute over the course of 2 years. Again, this is baseline. Yellow is NYHA class 3 and 17% is NYHA class 3 here, and 33% was class 2 here. So this many patients got converted from 3 to 2 over here, and in 3 only this many left. And this is the hospitalization reduction, 49% reduction at 2 years. So 1.3 to 0.66. And the mortality was 18.7. So there was no mortality. I mean, this was not a mortality trial, only 58, 60 patients, but more of functional improvement and echocardiographic parameters. So now we go to the second trial, and
Dr. Viti, Dr. Carlos Di Maria joined,
has joined.
So,
Okay. Good
yeah,
evening,
yeah.
sir, and welcome. So, Dr. Carlo, can you hear me?
Or you can go with the presentation. We will see.
Yeah, no, but because
I was told he joined. You can go back to the or
no, if he has joined and if he can hear me, otherwise I'll go ahead with this presentation.
Tech support, can you unmute Dr. Mario, please?
Sir, we have sent request to sir.
yeah.
Okay.
Right. Yes, can you see him on the video at least?
See his name, sir. His video is not on and he's not muted. I mean, not unmuted yet.
Okay.
I'm just trying, sir.
Good. So let us go ahead with this study in the meantime.
Yeah. We can go ahead with the study.
Yeah.
Yeah.
So this is the color trial which was presented now and also published in BMJ, a complex large bore radial percutaneous coronary intervention. So the color trial was a trial of comparing the radial route and the femoral route with 7 French or more than with 7 French guide catheters. So patients were selected, and if you see here that most of us avoid 7 French or more than 7 French through the radial route, but with the availability of slender technology, the use of large bore radial access has been done. So, but there was no randomized study on this, whether they are equally safe and whether there are complications with this. So this trial was designed for that. Primary objective to investigate whether transradial PCI is superior to transfemoral PCI with respect to clinically relevant access site related complications. Inclusion criteria, patients requiring PCI of complex coronary lesions using large bore guide catheters like CTO, left main bifurcation, calcified lesions. So these were the cases where we use generally 7 French guide catheters. Exclusion was STEMI, cardiogenic shock, and contraindication for femoral or radial axis, which means if the patient has peripheral vascular disease and in radial, if there are loops or something which cannot be overcome, then these were the contraindications for that. So this is 1:1 randomization, and primary endpoint randomized access related BARC 2, 3, or 5 bleeding or vascular complications requiring intervention at discharge. Safety, MACE and secondary access site complications at discharge and 30-day follow-up, efficacy, procedural success, and crossover rate, important. 388 patients, 81% male, mean age 69 years, and basal characteristics equally distributed. So 58% CTO, 19% heavy calcification, left main 14%, and 9% complex bifurcation. So all having, now in CTO, it was also that if there were bilateral routes, then one was radial, one was femoral. Also, these were also taken. Few were biradial also. So if you see here in the transfemoral 7 French, the 19.1% incidence of BARC 2, 3, or 5 bleeding and 3.6 in the radial, which was highly significant. And these were the secondary outcomes. The procedural success was same in both the two, and crossover rate of 2.6% in transfemoral and 3.6, but this difference was not statistically significant. So for patients requiring PCI of complex coronary lesion, 7 French transradial compared to transfemoral access led to significantly less clinical relevant access site complication. Procedural efficacy is highly comparable. So the limitations were, of course, randomized access site not blinded for the operator, primary outcome mainly driven by BARC2 bleeding, secondary access site use possibly influenced because of secondary outcomes. So in short, this is showing that 7 French transradial route with the slender technology is quite good and gives rise to less bleeding without compromising the procedural success. So implications in practice, and whether some of them have also used 8 French radial with the either the slender technology or with the Asahi new guide catheters which are available. And of course, the incidence of radial artery occlusion was not mentioned in this study, and whether there were any repeat procedures, radial procedures, how frequently they could be done with the same axis. Radiation time and procedure time was also not mentioned here, and radiation to the operator was also not measured. So I stopped sharing and then I ask comments. Dr. Carlo, you are on mute, sir. Can you unmute?
No, he still not got the connection, VT. We will discuss. Carlo, yeah, joined, yeah. Welcome, Dr.
But can you hear me?
Yes, very well, very well. Sorry for
Very
the.
well, good. We can
Yeah,
hear
good.
you also.
We can
So
hear you.
did you see the slides?
I did. It's an interesting trial, Happy to give share my ideas. And I mean, first of all, it's not a different technology from what we use every day. Unlike, using these dedicated catheters from Asahi that of course are 7 French, but are inserted without a sheath. They tend to move a bit more than what we are used. We can't really change 10 of them. Here you are using a sheath, the very thin sheath from Terumo, the slender, which honestly is my standard in 6 French for simple procedure. So you're just upgrading somehow your size to go after left main, CTOs, all the complex calcification and so forth. I confess, I think that that's the way to go, and I'm pleased to see this in a trial. Of course, in a way, the difference guided by a minor sort of complication like BARC2 is not as compelling as mortality or need for vascular repair or major bleeding requiring transfusions. Fortunately, even with femoral approach nowadays that you do most of the time ultrasound guided, looking that you are puncturing the head of the in the right place, guided by fluoroscopy across the mid portion of the head of the femur. That's much safer. Having said that, I think that the radial is unbeatable in terms of reduction of risk of bleeding, and the modern techniques allow you to do almost everything radial. The miniaturization, especially of the microcatheter for CTO, if you use Caravelle, say, or similar, Turnpike LP, for instance, you definitely can use a 7 French. You can even use 6 French. You can get a wire and a microcatheter with no problems, even a balloon and microcatheter with no problem. 7 gives you more freedom. The only technique, maybe not easy, is anterograde dissection re-entry, but I'm not so sure in your country how often you use these expensive Stingray balloons. In our country, we don't use that much, to be honest. So I would say my standard for CTO is 7 French, more rather than 8 French, with some rare exceptions. For calcification, I confess, maybe it's even too much 7, because I recently presented at PCR the 648 patients in the pooled analysis of DISRUPT, and vast majority of cases was done transradially, 64%, and majority 6 French, because it's a balloon and you can insert together with a wire all sizes. So do you really need more? And in fact, also rotablator and now orbital atherectomy you can do through 6. Same, my standard for bifurcation, so the left main is a large bifurcation, is a double decay crush, and is a technique that doesn't require 2 stents together. So you can do theoretically with 6, better with 7, because if you have a 3.5 and a 4.0 kissing balloon finally together, it's definitely easier with 7 French. So I think in a way is what is expected, but when you see it in a trial, you feel more confident to follow your practice.
So how much percentage is femoral access in your lab now?
15, 20%.
Yeah, okay. Ajit, your comments?
Yep. So thank you, Carlo, for your very valid comments. And my lab has almost 70% radial and 30% femoral. We used to elect to go for the complex cases more through the groin, especially when you're using rotablator or 2 balloon systems, or you want to do difficult systems, because in 6 French sometimes it gets a little bit difficult to do this. And the slender sheet definitely makes life simpler for that. I have one comment on the trial. There's 19% outcomes in the femoral seems to be pretty high. I don't think that's the number which you normally see, even if you consider it as BARC2 bleeding, compared to the radial of 3.9 or 3.8. But I think that seems to be a little too high in the era of micro puncture needles and, femoral head punctures. I don't, even BAC2 bleeding is a bit too high. It's a soft indicator. I agree with Carlo, that's a soft thing. It's not like big bleeding or some mortality difference. But even that, 19% is a bit too high for me to digest in this study. So your comments, Carlo, on that? What do you think, Carlo? Is that 19% a bit too high for the femoral?
Well, I think it all depends on how often, how carefully you look at your patients. If you are considering a minor hematoma carefully, or some loss in hemoglobin, you will see it more often than you expect. I think part of the reason why we see very low figures for many registries is that they are not major events. They are not hard events. It's not something that you have to report in any mortality or morbidity meeting. Then they are scotomized. They are trying to forget it somehow. So I don't know. Maybe it is. However, it is a long procedure. That's the other issue. Is of course, if you do a short femoral with little heparin, half an hour procedure is a different event rate. But sometimes you see this hematoma also at the end of the procedure, even if you had a single stick. So it's a large artery and does bleed.
Right. Yeah. And these were all 7 French and complex cases. So maybe a bit too long. Balbir, you have anything to add on this?
This trial actually helps us to be more positive. We do almost 90% transradial, and 7 French slender sheath is the most ideal. And we don't find any technical, I don't remember a single case where I had to switch from a radial puncture to a femoral. I don't remember a single case in the last 1 year where a 7 French transradial was not helping and I had to switch over to a femoral. Not a single case. So it is clearly a big advantage, and I feel that this trial just makes us more wiser that we should continue our practice of a transradial approach more often.
Yeah. Dr. Mahesh?
Yeah, see, even we are doing majority as a 80% transradial only, even if it is 7 French. My only personal thing is that it is much more comfortable to do any procedure when you're doing a transradial rather than transfemoral. The reason being slight difference in the height of the table, the nearness of your table to your chest or to your abdomen makes it very simple, very easy to operate rather than femoral. We were doing it femoral to start with, but femoral radial is always more comfortable for the operator.
Carlos,
the
one
patient
question.
Also. Yeah, sure, of course.
Yeah, Carlos, one question. What about the PAMI? You always PAMI setting?
Sir, we are doing every day, almost every week, 3 PAMIs, only radial.
So Sada, one comment before Dr. Carlo comments. In this trial exclusion criteria was STEMI patients and cardiogenic shock patients. So they wanted to take only the chronic stable cases, and as per recommendation, of course, all STEMI ACS would go for radial unless cardiogenic shock and person doesn't want to go. But yes, Dr. Carlo.
No, that's why I wanted the opinion, Balbir, Ajit, and Dr. Carlos about the PAMI setting, acute STEMI situation. Still, you should go ahead because the time factor, puncture, and all.
It's always primary patients go radial. Always in our hospital.
The duration
that and the thrombolyzed patients always, pharmacoinvasive is always radial. The only cases where we used to do was complex cases with a lot of calcium, and we expect trouble with road ablation and 2 balloons, 2 stents going through up and down when things become a bit sticky in a 6 French system. I think the 7 French system is fantastic, the slender sheath. I think it's a very beautiful system. And I think the Terumo hardware is fantastic. There is no doubt about that. At the same time, I have to also breathe in that, the the femoral problems have also come down with time because of less aggressive anticoagulation, better management of the groin by punctures and closures. So I think that, I think slender sheath is fantastic for the patient, fantastic for the doctor, except for the radiation. But otherwise, I think that it should be the mode of way of access in most patients.
Well, thank you for asking my opinion as well. Of course, STEMI, I think, is the classical indication where it's much better to use transradial because our standard is cangrelor, so intravenous P2Y12 inhibition, which of course has a slightly higher risk, at least of immediate bleeding, is much more powerful than anything else, overcomes the limitation of gastric absorption, but there is definitely a minor risk in bleeding, and also Phoenix showed it. Champion Phoenix showed it. Occasionally you may need to add to that eptifibatide. That's not standard, but maybe 5%, 10%, you will have some no reflow. And what's the drawback of using transradial? Very little. I see some colleagues who do it when there is, very slow heart rate, bradycardia, or some true AV block. But then you go for a femoral vein that's different from puncturing in artery, which is much higher risk of bleeding. And of course, there are a few cases that will need femoral puncture because you need an impeller. Well, that's another story. Of course, in theory, you can use the impeller through the same, do the angioplasty through the same sheath, but that's, is not a reason to choose a femoral to start. If the patient is really in shock, most of the time, impeller is not enough. You will need ECMO to make the patient survive. If you see that there is a complex anatomy and the patient is with an impending shock, you will have your procedure transradial, you keep doing transradial, and you put your impeller in to support it. That's the way we tend to do it.
So one question, Dr. Carlo, you said cangrelor, where is it given? In the emergency, before the puncture, or?
No, now the standard, and if you look our guideline, they are really prescriptive. You need to see the anatomy, and even for STEMI. So it's almost of course, it's class 3 for Pras-Ugarel, but whatever.
Thanks.
STEMI, I don't know.
So we go ahead with the next very important trial now, and which should generate a lot of questions and comments. So let us go to that. Where is that gone? Yes. So the EBC main, the European Bifurcation Club left main coronary stent study, a randomized comparison of stepwise provisional versus systematic dual stenting strategies. So the background was many trials have shown lack of benefit associated with systematic two-stent strategies for bifurcation. We all know that Nordic, BBC1, BBK, Cactus, and so on. And most of them have shown worst outcomes with the dual stent strategy. Now, left main bifurcation, we all know, is a different animal because of wider angle and big, large size vessel, more calcification, fibrosis, and greater need for vessel preparation. So two-stent techniques may be expected to be worse. Ample evidence from non-randomized trials showing worse outcomes. However, randomized data from Dr. Shaoling Chen, the DK Crush trial showed better results with the two-stent technology. EBC main was designed to examine clinical outcomes in patients with true bifurcation left main stem lesions, that is 111 or 011, randomized to stepwise layered provisional strategy versus a systematic dual stent strategy. The primary endpoint, death, target lesion revascularization, and myocardial infarction at 1 year. Myocardial infarction, please remember here, is not specified to be target vessel or non-target vessel. It's a general term, as against in DK Crush where it was target vessel myocardial infarction. Secondary endpoints, death, myocardial infarction, target lesion revascularization, and stent thrombosis. So provisional approach was a step-by-step layered technique as described in the EBC consensus 2009 to 15, POT mandated and KISS mandated. Systematic approach two-stand strategy, the choice of two-stand T, tap, culotte or DK crush was left to the operator. Step-by-step approach according to the EBC consensus, high pressure ostial bifurcation dilatations and KISS mandated plus minus final pot. So to note, 60% of them was sheath 6 French and radial root was 70%. Number of stent at bifurcation 1.1 in that is sorry. Yeah, let me just change this. Maybe it would be better. Yeah. So here, if you see the difference between number of stents, stented length, procedure duration, fluoroscopy time, and air karma, everything more in systematic dual stent technique. Procedural flow, main vessel preparation 88%. Again, here, the only thing to note here is the pot 85% in stepwise provisional, 87 in systematic dual. Kissing was in 89%, so 11% did not have the kissing there. Then final pot 81% and 84% here. Now, one important observation to see over here is preparation of the side vessel 49%. Generally in the provisional we say not to touch the side branch. Balloon was 43, cutting balloon 6, rotablation 6, none lithotripsy over here. So that was the thing. Then the stent diameter of the main vessel was roughly 3.5 plus, that is 3.8 and 3.6. No problem with that. And as I said, the two stent strategies, 53% was culotte, only 5% DK crush, 32% T or tap, unstated 4%, missing data 3. In stepwise provisional 99%, of course. Wire jail was 82%. The TIMI zero flow was only 1% in the provisional strategy. That means very few, hardly 2% at 0 to 1 flow. Most of them had TIMI 3 flow even after the provisional stent. Of course, pot we said 85. Now, so the other thing to note over here is, of course, the rewiring was almost 95%, 93% successful. Hardly 5 to 7% was not possible. Kissing balloon, as I said, almost 11 to 12% not possible here. And 22% crossover to the second stent in the provisional strategy. Okay, so and out of that 11% was culotte and T or tap 11%. So that was the observation here. Then out of that 22%, dissection was in 10% and residual stenosis more than 90% was in 12%. So that was the indication to put the second stent in the provisional strategy. The other important thing is that the size of the second stent was also 3.5 and 3.6. Okay, so and as I said, 6 French guide catheter was used in almost 60% of cases, and where a kissing balloon was done with 3.52 balloons was successful through that. Okay, so then we go ahead. Now stent length in the second vessel is 17.6, whereas the lesion length more than 7 millimeter was not considered in the provisional strategy, but the lesion length was 7, but this was 17, and I'll tell you the difference will be important in the further slides. Okay, so final part we all discussed, 19% could not do in the provisional strategy, 17% final part was not done over here. Okay, the IVUS. IVUS was 36% in provisional, and in dual it was 31%, significant. Then the re-intervention resulting in 12% in the provisional strategy after IVUS versus 6% in two-stent. OCT was only in 4 and 7%, and FFR only 4 and 1% over here. So which means what? Which means FFR was generally not done for the side branch vessel, whether to be stented or not. And the primary endpoint, No difference. No difference in primary endpoint and no difference in secondary endpoints of death, MI, target lesion revascularization, and stent thrombosis. 1.7 slightly more in provisional than in the dual strategy. Okay, so stent treatment of true bifurcation left main stem coronary disease had generally good outcomes. Numerically fewer serious adverse events with stepwise provisional approach. Procedure time, X-ray dose, and consumables were less. Only 1/5 of patients in provisional group required second stent. It is not necessary to prejudge the issue and start with a non-provisional two-stent approach. Patients are treated equally well with a stepwise layered provisional approach, starting with a single stent as with a more complex dual stent implant. The stepwise provisional strategy should remain the approach of choice for the majority of left main bifurcation interventions. Stent treatment of true bifurcation is safe and effective. Patients are treated equally well with single and dual. When a provisional stepwise approach was used, only 1/5 went to a second. The provisional approach should remain the philosophy of choice in the majority of left stem true bifurcation procedures. Now the most important slide. Difference between EBC main and DK crush. Almost the same number of patients, 2021, 2017. This is European trial. This is Asia and one center in Italy. Syntax score 23 in EBC main and 31. So highest syntax score in DK crash. Side vessel lesion length 7 millimeter, but as I said, the stent put in was 17 millimeter. 16 millimeter over here, stent size was 19 length, sorry. Crossover 22%, crossover 45%. Culotte 53 and T-tap 33, DK crush 100%. I was used 36%, 41%. Primary endpoint death MI TLR, cardiac death TVMI, okay, target vessel MI, not other vessels, and TLR. And see the most striking important difference. 14.7% provisional here and 10.7% provisional here. 17.7% two-stent bifurcation mace, only 5% in DK crash. Such a vast difference between the two. This together was non-significant. This was significant over here. So my comments and question. Was this trial more disappointing? No statistical difference between provisional and two-stent. So it's left to the operator. Increase mace as compared to DK crush phi in both arms. Why? Why side branch predilatation in 46%? Side branch length 17.6 millimeter. No, the stent length 17.6 millimeter appears to be too long for 7 millimeter lesion in the side branch. Finally, is it the operator discretion to use provisional strategy or two-stent strategy as per EBC main, or follow the definition criteria and choose DK crush phi? Future trials of left main bifurcation, European provisional strategy versus Asian double key strategy, I think should be done. So I'll stop share, and now Dr. Carlo for your comments overall.
Thank you for giving me the first word on this very interesting trial. Well, I mean, it's a large series, but what you miss, as always in these cases, is where do you start from? How many patients with left main bifurcation did they treat in the meantime? How many of them with very severe osteostenosis of the circ went directly outside the trial into two-stent strategy? And that's, in my view, without this information, it's very difficult to judge the trial and to put it in perspective with other trials that, as you pointed out, had different outcome. In my view, it's is a 1-1-1. I mean, the final one has a little bit of question mark, because the length of the lesion in the side branch is on average 7, which I mean, I don't know how much it was the standard deviation, but means some were really nearly osteostenosis that can respond to balloon. may have a better outcome with provisional than what we consider a real side branch stenosis. So that's the first point. I think is a population that was selected to get a certain outcome. That's my view. And I think I like to leave the word to our colleagues. I have a few more comments, but please.
Balbir, you start this time.
Okay, so my opinion is that provisional is a great strategy, but none of these, some limitations of these trials, both crush and this, is that the use of intravascular ultrasound or OCT has been very low in both these trials, which is very unusual for most operators who do left main bifurcation. Almost 90 to 100% use of imaging is there with these. So the 40% imaging is not good on any trial. It's a very low number. That's the first thing. Second thing is that none of these trials determine or tell how big is the circumflex. You know, sometimes the circumflex is non-dominant. A provisional stenting is a great idea in that strategy. But if you have both these dominant and you have an osteal lesion on the circ, you will not go with a one stent strategy. So you are already biased in your mind that you have dealing with a very big circumflex. These trials do not answer how many had a dominant circ. They just mention that it is a left main bifurcation. And you see that every day. Sometimes you have a very small non-dominant circ and you just put one stent. You don't bother. You just want that patent. You don't bother whether there'll be some osteal narrowing of the circumflex. And there are areas where you have a 70% osteal circ and that's the only dominant vessel. The RCA is non-dominant and that has a different outcome. So patients are individualized. To put one into one trial is very, very difficult and say that this is the best strategy. So every patient is different. And decay crush was done with one group of operators who are biased towards decay crush. It's a technique which cannot be generalized. So it's not an easy technique to follow, needs a lot of steps and has to be done very carefully. So one has to remember that always.
Dr. Mahesh, let us take yours first and then last, Ajit. And then we come back to Dr. Carlo again.
Sir, as Dr. Balbir said, it is actually not possible to understand and imagine that the results were not significantly different in a patient who had a large circumflex with osteal stenosis. And we would not leave that. We would not leave it to provisional stenting. We will always go ahead with start with a two-stent strategy. So trials definitely cannot answer all these questions. We'll require a very large number of patients to be followed for a very large time, and there will be multiple things to randomize. It will actually be a very complex thing to do it.
Ajit?
Yeah, I think this trial is a typical European trial. You know, no decay crush, provisional, no IVS, you know, keep it simple type of strategy, sort of scenario, and, you know, trying to simplify a complicated issue with a simple randomized trial where the entry criteria is not clear, like what Carlos said. You know, I think these things need to be categorized a little bit more. So if you have a example like Balbir and Carlos said, if it's a big circumflex, the length of the lesion, the circumflex is big, I don't think anybody will go in with a provisional strategy in that scenario. And whatever you do, whether a crush or decay crush or a culotte, you can choose what you want, but end of the day, you will always finish with an imaging. And I think that's common practice, what you normally do in your practice. And I think what we should simply say is you're trying to compete with a surgeon who gets a very good result in these patients. And if you don't get that surgical outcome of edema to LAD plus a nice graft to the maybe you know, the OM or the PDA, I think you're not doing good for the patient. So my comment is this study is a bit unsure. I wouldn't take this study very seriously in its form that it's presented. You know.
No, but Ajit, yeah, just one comment before Dr. Carlo says. As I said, all these years, if we were to hear all these European experts, they always used to say provisional is better than two-stent strategy. the side branch arm restenosis is higher. The mace rate in the side arm is higher. So we used to hear all this. But now this trial doesn't show that what they were always, I would not say teaching us, but always used to tell us. So now, Dr. Carlo, let us hear from you as part of the European club.
Maybe Dr. Shetty wants to have a word first.
No. Dr. Shetty, you want to ask anything?
No, Carlos, I was always, wondering this European and the Asian, sort of a difference all the time. In fact, we were always interacting with Dr. VT Shah, this Asian versus the European, like many times I heard a European speaker, I don't do DK crush at all, zero. I've heard that, few of the European speaker, I don't do DK crush like that, So I don't know what is the concept in this, So you have to clarify.
Let us hear from you first about the trial and then about your own practice, Dr. Carlo.
First of all, I'm not a member of the bifurcation club. I'm the president of the something else. And I'm a good friend of Yves Louvard, of Thierry Lefebvre. I think they are very important. They showed us how to do it bifurcational strategies very well, how to do T-stenting that, in the 90s, very few people were doing, were approaching bifurcation with stents. I think this is a historical method. As often, things move on and you don't have to stick to the past. You have to move on as well. And believe me, not many people in Europe really use this dogma of provisional as the only way forward. There are many centers, and I've always followed with Antonio Colombo this rule. When you have a large second vessel and there is severe disease, you always have to place a second stent, and 20% on such a vessel makes no sense. That's why I say probably they were extremely selected. And was very good. The comment is also the size of the circ. If you have a very hypoplastic circ, who cares? But these were super selected cases in my view. So you pointed out to one trial, provisional versus DK crash, but there are trials of DK crash versus culotte.
Yes.
DK crash versus T-stenting, and it does better. So why? Because it fits more anatomies, while culotte fits just a sort of relatively acute angle and T-stenting a 90-degree angle. DK crash is really almost able to cover the majority of anatomies you have to deal with. And in the left main, the angle can be very, very variable, from extremely acute to retrovert circ. So, and with DK crash, it does work. I think that it gives higher chances of ever 99–100% success in final kissing balloon, which is very important because you have done your initial preparation of the lesion once you have placed, once you have scratched the stents for, in general, the circumflex, reopening in part this ostium, and then it's easier to come back a second time. While if you do with other techniques, you have more difficulties, and some 4%, I would say, they are good operators to be able to do it in 94% of cases with final kissing, not using DK crash. And then all the other comments were made by others. Intravascular imaging, not doing it, especially when you have two stents, that's not good clinical practice. And please, European guidelines say class 2A. So they were against the European guidelines, right?
Right, yeah. So they were biased.
Europe, not the main European standard, okay? Well, I think is interesting trial, published well, but will not change my practice, on the contrary.
So finally, tell me, in your two-stent strategy, how much percentage they vary? DK crash versus culotte versus T-tap?
I think the vast majority is a DK crash when I decide to do it from the start. If I have a provisional and for some reason it doesn't go the way I expected, then of course it will be a little bit a difference according to the angle. And often I will go for T-stenting or TM perfusion, but will not be that often because I tend to use upfront a two-stent strategy whenever I have a severe long lesion in a large circumflex.
Excellent, excellent, sir.
Yeah.
So one question from Dr. Bharat Shivdasani, how much percentage had rotablation? Single digit. And the side branch vessel stenting size was 3.5 and above. So that was another question from Dr. Dinesh. So we now go on to the next trial. Let us see. I will share the screen again and go now to our next trial. Okay, so I have to. So now these two trials are actually based on mitral. So I'll take them together and then we'll have comments. Safety and efficacy of Mitra clip in acutely ill NYHA class 4 patients with mitral regurgitation, results from the global EXPAND study. So these were patients of MR with NYHA class 4 and Mitra clip was used. The objective of the present analysis was to assess the impact of Mitra clip intervention in the acutely ill heart failure patients characterized by class 4 in the real world contemporary setting. So almost 1040 patients with for Mitra clip, out of which 922 were 1, 2, and 3 class, 118 were class 4. So the study more focuses on that 118 group. So here, as you see, that the class 4 had higher rates of secondary MR etiology and significantly more dilated ventricles than the class 1, 2, 3, and excellent procedure outcomes observed for all patients irrespective of baseline NYHA class. Now the change in MR grade by baseline NYHA class was also significant. Improvement in MR grade was achieved and maintained through 1 year follow-up of all subjects irrespective of the NYHA class. Event rates in NYHA class 4 subjects in EXPAND are comparable to the Mitra clip arm in co-op trial. Now, if you see here, the all-cause mortality in class 4 was more than in class 1, 2, 3. This was 32.4, and in the medical therapy arm of the co-op 1, the mortality was 40% over here again. Yeah. So it was 40% in the medical arm in the co-op trial where Mitra clip was used. And here it is 32.4. Heart failure, hospitalization, again more in class 4, 29.2 at the end of 1 year. But in the co-op trial, it was 58% in the medical arm. So better results than the medical therapy arm. The quality of life improved. So results strongly suggest substantial clinical benefit of Mitra clip technology in this acutely ill patient population with poor prognosis and otherwise limited treatment option, and support earlier observations that were Mitra bridge, RME, TRAMI registries, and in patients with cardiogenic shock. Now this is another device, 2-year outcomes for transcatheter mitral repair from the CLASP study. So this is the Pascal platform which is used, the Edwards Pascal transcatheter valve repair style. Here again, the patient with significant mitral regurgitation was used. The MR was more than or equal to 3 and NYHA class 2 to 4A. So if you see here that at 2 years, the all-cause mortality was 15.3, heart failure rehospitalization 13.7, and these are the 80% survival and 84% freedom for heart failure hospitalization at 2 years. The MR significantly came down. There was positive LV remodeling. and 93% of patients with NIHA class got benefit and came down to less than 2 at 2 years. So this is the 2-year outcome of 124 patients, 2-year results, 80% survival and 84% freedom for heart failure rehospitalization, significant MR reduction, 78% MR less than or equal to 1 and 97% MR less than or equal to 2. So 2-year outcomes with the Pascal repair system demonstrated sustained high rate of survival and freedom, durable MR reduction, and significant improvement in functional status. So the class for 2D, 3F randomized pivotal trial is ongoing. Comments. How would you look at both these results? Personal experience and choice of one over another, and is the scope for TMVR increasing with the passage of time? So your comments, Dr. Carlo, and your experience.
Well, I mean, mitral clip, I think, is definitely here to stay. It's a technology that has been proven in randomized trials, especially in the setting of decompensated patients with secondary mitral regurgitation. And in coat, especially, which in my view trumps whatever comes from the France MR different outcome. Here we have a trial focusing on class 4. We had a similar registry in the past that was done in the setting of the TRAMI trial, the larger German registry, and it also pointed out there is quite a high mortality. Also, figures were roughly double than what you will see here. I don't know whether the difference is due to the different characteristics of the patients or to better experience of the operators achieving a better results. And I think it's probably a mix of both of them. First of all, I think placing a mitral clip in a class 4 patient is already a failure. Means you didn't spot the problem in time. Because the best results, as you have seen, is when the patient is still class 2, class 3. If you wait too long, just trying 1,000 drugs and Entresto and this and that, well, you end up that the patient comes to you already with pulmonary hypertension, right heart failure and tricuspid regurgitation. Even if you get a good outcome with your clip, the final result will never be the same, and the patient will possibly remain partially in failure. We tend not to use this approach. When we have a class 4 patient, we do our best to at least see him coming out of hospital for some time, to go back the scale to class 2, 3. And then we tend to apply to those patients who remain with severe mitral regurgitation, mitral clip implantation. If you don't do that, I think you will pay a price. You have seen the curves, you know, they diverge at the very start. So you are wasting 20,000 euro in 20% of patients who die after 1 month. I'm not so sure it's a fantastic option. Different story, but I don't think there are patients in this group when you have acute failure in a STEMI or rupture of a papillary muscle. That's of course extremely difficult, and we are speaking of the few patients who are truly inoperable. But here we are speaking more of advanced heart failure. In these cases, I think do your best to improve the situation medically, and then use the clip to stabilize it in a second stage. That's my start. I don't know if you want me to speak about the Pascal as well, the Pascal trial. I can't hear you.
We can't hear you.
Yeah, sorry. You can go ahead with that comment. Then we ask Dr. Ajit and Dr. Balbir to comment.
All right. So, I mean, first of all, Pascal, I think is fantastic to have a second device. You have seen the moment that they, before they came in, they already started to make improvements in the mitral clip. Before, it remained the same for 15 years. And then suddenly they came with longer arms, and now you have a family of mitral clips with wider arms, with independent movement of the two grippers, offering almost the same capability of Pascal, with the only difference of having this, not having this spacer, which is in the middle, which has some potential to avoid stretching the leaflet too much. I'm not incredibly convinced that this makes a tremendous difference. I don't have enough experience with Pascal to say that that's equally good or easier or whatever. However, I'm impressed by the results. They are very good results. I don't know how much of these 12% mortality at 2 years is related to super selection of cases. When you use a new device, you tend to have a committee telling you can do in this patient if the patient has hemoglobin low or whatever problem out. So that's the only issue. But the data on final remodeling of the ventricle and atrium, on residual mitral regurgitation, if I understand well, is core lab adjudicated. That's quite good. That's quite impressive in my view.
Yeah, Ajit?
Yeah, I think mitral clip has really improved in the technology I see. It's become much more better. And I think part of the outcome differences which you saw between this study and the other previous studies is because of operator experience and the clip getting better, number one. I would completely agree with Carlo that getting a class 4 patient is the last patient I want to do a clip on. I would look at all the other ways of trying to handle this patient, because there's a tremendous loss of resource when you, especially in a country like India, where I think you have to reserve your money for better things. And I would possibly go with what Carlos said: treat medically, stabilize the patient acutely, get him better, review the position. And if he's in class 2 and 3 and he doesn't have severe PH and severe problems, and it's not an acute issue and the ventricle is not completely fired, then maybe review the position and try a clip on that patient. But otherwise, I don't think that's a very good option. And we'd look at other options which may be cheaper, including a transplant if it's a younger patient, because that may be a better option even in India. So I think that's the way I will look at that trial. I think the Pascal, I have no experience, I've never seen it, so I don't know. But from what the paper shows, it seems to have a very good outcome, because I'm not sure whether they selected these patients too well to get that outcome. But what I like is that there are now 2 clips, and if we can get 3 or 4 clips, 2-3 things will happen. We'll all get the handle on these clips better, and the cost will come down. Yeah. So it'll help our patients. That's my conclusion.
Yeah. Balbir?
Mitral clip is going to stay. It's a great technology, and secondary MR is a big problem. And we have huge number of patients. The problem is the cost. The cost is going to be really a big factor in our country to treat so many patients, realizing the fact that you make a person who has an ejection fraction which is very low and has MR, and you spend so much more and still does not have a final answer. So that's what is going to keep this technology away from many patients who really deserve it. So, but it is a great technology to have.
Right. So we go on to the next presentation. And so right here, I hope I go straight to that. Yeah. So complete versus incomplete revascularization in end-STEMI patients. End-STEMI patients often have multivessel disease, but the impact of complete revascularization CR has not been fully established in this patient group. So complete, and if you see the guidelines about 2020 ESC guidelines, complete revascularization during index PCI may be considered in end-STEMI ACS patient with multivessel disease as class 2B, level B. We have enough evidence in STEMI now, and we have enough evidence in chronic stable angina. Gap in NSTEMI treatment strategy unless unclear whether coronary revascularization of the presumed culprit lesion only or complete revascularization in NSTA ACS patient should be attempted. So this was a study, multivessel NSTEMI, and this was using Ultimaster stent, and this was a registry with 37,000 and odd patients being included. So if you see here, basically, finally, there were about 1,800 patients in the complete revascularization arm. Now, please remember that complete revascularization was in the index hospitalization. If you were to stage it and the patient goes home and then comes back again, then that was not CR at index hospitalization. So incomplete revascularization at index procedure, around 2,000 patients and around 1,800 patients here. So this was the essentials, yes. Now, if you see here, target lesion failure, significant, then patient-oriented composite endpoint of death, myocardial infarction and revascularization, significant, cardiac death and MI, significant, all-cause death, significant, cardiac death, of course, significant, any MI, significant, TVMI was not significant, and the TLR was, that is the complete revascular TLR was not significant in both the arms, non-TVR significant, any revascularizations, and interestingly stent thrombosis was not significantly different. So risk profile of NSTEMI patient who underwent complete versus incomplete. After adjustment for all baseline differences, patients with CR compared to IR experienced significantly lower rates of all-cause death, composite of cardiac death and MI, any revascularization, and patient-oriented composite endpoints. So our findings suggest that a physician-directed complete revascularization strategy with the Ultimaster stent results in optimized clinical outcomes in all those all-comers and STEMI population. So it could be staged within the index hospitalization that was allowed. So this is a registry. This is not a randomized trial. And patients with a stage revascularization after the index hospitalization were not included in this analysis, as I said earlier. So we said about the endpoints, I had, yes. So we have complete in STEMI. We have the concept of residual syntax score more than 8 in chronic stable angina, which leads to more MACE and events. And this is an NSTEMI. There is no randomized big trial now. SMILE was one trial with a single multi-vessel PCI one stage versus multi-stage, which showed that single stage multi-vessel PCI was better. There is another Korean study which showed no advantage. The ESC guidelines, as I said, is class 2B. CTO's LV, severe LV dysfunction would be a challenge during the same index hospitalization, and any role of FFR that is not addressed anywhere. So let us hear the comments of Dr. Carlo first, and then we go on to others. Complete versus incomplete in NSTEMI.
Well, thank you very much. We will have a big editorial coming up, a review rather than editorial state-of-the-art paper in neurointervention. First author is Valeria Paradis from the group of Rotterdam, and Tony Geslick was one of the co-authors. He managed to contribute before his premature death because of COVID, as you know, in November last year. And of course, STEMI is very clear. You have to do it, right? The only question is whether you do in the same setting during the primary angioplasty or within the same hospitalization after a few days, as we tend to do in most cases. No STEMI, still the judge is out, the jury is out. And I think the registries like this help because they indicate that there is a likelihood of having a similar outcome if you apply complete revascularization in non-STEMI patients as well. You expect to have the same outcome because it's a similar process. In acute coronary syndromes, you often have lesions even non-critical lesions sometimes that are at a higher risk of rupture. If you have a critical lesion and you don't touch it, the likelihood is obviously much higher. They tend to be lesions that are more active than in stable syndromes. So I believe the data. I think they will help. Unfortunately, will not change the guideline unless we manage to put together enough resources to do a large trial like we have for STEMI and to confirm that this is the case.
Yeah, right. Dr. Mahesh, your comments? Unmute yourself.
Yeah. So as has been said that we are using it for STEMI patients very commonly, that we do the target lesion on day 1, and on day 3 or so we go for the other lesions. Stable angina, so we can do a number of cases, n number of lesions at same sitting. And STEMI, there was no significant data, but then we were practicing this only, that to do only one lesion on the day 1. Maybe we advise the patient if he is willing for angioplasty of other lesions on day 3 and day 4. Otherwise, stage it to second sitting. And now that we have at least some data which says that if you do single stage revascularization, complete revascularization, it stands better than doing it in stages. So we will try to follow it unless we have a randomized data which goes against it.
Ajit, your take?
I'm glad that there's some good work coming out of non-STEMI, because everybody is worrying. You have millions of studies and millions of randomized studies in STEMI and chronic stable angina, and non-STEMI was, just left there as if it had no importance. And if you really look at the one-year outcomes of non-STEMI, it is as bad as STEMI. So I think that it is time we got some good studies out in non-STEMI, number one. I don't think, like everybody else said, that there's anything different in the pathobiology or physiology of STEMI and non-STEMI. Both are ACS. In both there are culprit lesions, both there are activated platelets, both they have multivessel disease many of the times. Most of them will have critical lesions and non-culprits. And I don't see any reason that we should behave differently for non-STEMI than STEMI. Well, I also agree with Carlo. To move that up to a class 1 guideline, ultimately you need a randomized study. And for that, I think you'll need to get that done so that to move the technical, make it class 1 in a way. But it's not going to change my practice, because I do exactly what this study does in most of my patients, just like I behave with STEMI.
Balbir?
Dr. Shah, if we talk of practical things, what you and I, or what Ajit does, or what Dr. Mahesh does, if a non-STEMI patient is there and has multiple lesions, we know they're generally more stable than STEMI, and we like to finish them in the one sitting rather than, unless there is a problem on table with the first lesion. We don't want to, wait for another time to do the other lesions. It is very cost effective to do everything in one time if the renal parameters permit. It is always logical to treat all critical lesions, not only there's the culprit lesions. For a purpose of a trial, this randomized trial actually is not a randomized trial, is a registry, does not actually contribute to anything different to what we are doing, or nor will it change our practice of, suppose you have an LAD culprit and you have a critical lesion in RCA. Will you wait for that patient to not treat that RCA? It's not going to happen. You will do it there and then. So it's logical that the results are logical to what we actually do.
Yeah.
So one question to Carlos and all of you. I've been hearing your comment. So conceptually, do you require a randomized trial for NSTEMI? As last comment what Balbir said, and this is what we have been practicing, See the STEMI part, because of the whatever, though the pathophysiology is a similar ACS, we are talking about, doing the non-culprit regions, the same sitting, maybe some problem of the stent thrombosis or some event. Whereas in NSTEMI, we have been practicing, what Ajit or Dr. Balbir and even Mahesh mentioned. Do you really require randomized trial to get into class 1? Carlos?
Dr. Carlo?
Well, unfortunately, yes. I mean,
yes.
Organization and
because guidelines follow their own guidelines.
Exactly.
No,
And
then why
the problem is that it's not us doing the guidelines. Maybe I don't know whether you have similar consensus document in India, but you will have in the revascularization guidelines, out of 100 people, maybe 30% interventional cardiologists, 20% imaging, 30% clinical cardiology, 10% cardiac surgeons, and then a mixture of somebody else that do health economics and strange things. So that's the group in the guidelines. It's not us, right? We are convinced. We can already give class one A with the diamond. So the problem is that these trials are very difficult to do. In STEMI, in a way, is more logical. You have done, you have the patient, we have done the major issue, you have solved your main problem. You have a few other things, but we don't know exactly what to do. And we will get you back at a later stage if you have symptoms. Right? That's work. If you tell a no STEMI patient, I could have done everything, but I leave you with some extra lesions that probably will need treatment because we do a randomized trial, will not be so happy. And then you will start selecting patients. You will say, it's a little marginal. I don't know what to do. That's a good patient for the trial. And then you do capture, you do all these useless trials that come up with no results. I mean, think of the only trial in STEMI patient with CTO. Explore CTO. Nothing came out. Maybe it was too short follow-up. You may ask yourself, maybe they did a too early procedure because they did within the same hospitalization is CTO. What's the hell the reason of doing it? You just wait a few weeks that the patient gets more stable, probably better. The results were not the best. The recognition was 75, 80%, but still was a negative, was a trial that didn't show any significant favorable difference, even some mortality against the treatment of CTOs. So there is the same bias. You tended to do the more complex CTOs and the relatively smallish vessels. You don't know whether it's good or not to do it. How to find a solution? I don't know. Maybe countries where either people don't have the resources to do all the vessels, or there is a sort of social medicine where everything is decided. China, maybe. That's the only country I see where a similar trial can come out, because my practice, it would be very difficult for me to randomize in a proper fashion my patients.
Right. Carlo, on that count, my last question in that slide was about FFR. Now, what has happened is, in STEMI, even FFR, some trials showed benefit. The latest flower MI in ACC recently published, angio versus FFR guided, did not show much, did not show any significant difference in patients angio guided revascularization or FFR guided. So in STEMI, do you think FFR has a role, or angio guided is good enough?
Well, I mean, the current guidelines from the European Society that I don't think many people follow in Europe as well, say that if you have a less than 90% degree stenosis, you should do FFR all the times, right? Or physiology all the times. I think there is probably a way, a middle way in between this extreme and not doing it all, which is probably the most diffuse practice. These are no STEMIs, so you have no idea whether a 50-60% lesion is inducing ischemia, because you have no possibility to do any test before, any non-invasive ischemia evaluation of these lesions. I think it's an ideal target for physiology. Physiology has improved because you don't need adenosine, so you overcome some the limitation in acute patients, that these patients may have not the same brisk response to adenosine and hyperemia than chronic patients, and the limitation that, of course, when you do a super complex procedure, doing a 3-vessel FFR, that's time wasted and so forth. So using resting index of physiology, I tend to prefer IFR because, you know, I was very close with Justin Davis and his group in the validation, but the differences don't seem extremely big also with other rest indexes. I think it is a good alternative when you have 50, 60, sometimes 70% short lesion in right coronary or circumflex. And you have the other advantage of the modern approach is that, unlike the FFR champions that were a little bit like the Euro bifurcation club, there is only one way of doing provisional, right? Now these 0.8 cutting edge of threshold of doing or not doing is interpreted with a grain of salt, which is look at the down lesion, and if you have a value that is intermediate, 78 or 82, you just do it when it is logical. So if it's an extremely complex lesion where your outcome is very questionable and you have 81, maybe think over and just let it go and see whether the patient is ischemic. If it's super simple and is 78, do it. So that's the way the technique has evolved, except some, as you know, there are always the Talibans, I call it, of physiology. I'm not a Taliban of anything. To apply my judgment.
Excellent, excellent, Dr. Carlo. I'll just answer. Dr. P.K. Goel has asked 2 questions, and one of them, Dr. Carlo did mention that you are right, it would not be ethical. So he said we will randomize those patients where we are doubtful whether the revascularization would be helpful or not, so send them for randomization. So that would be that group which will have. And if it is non-culprit CTO or some complex diffuse disease, as he said, that there was a study in this Euro PCR also that CTO with LV dysfunction did not show improvement. Well, actually, I did not include because it was getting too long for discussion. Therefore, I did not include in today's discussion. But yes, you are right that non-culprit vessels, CTO or complex diffuse disease would be difficult and maybe give bad outcomes. So we go on to the next now. I think we are almost nearing the end. Let me see. Yeah, so this is another important study which got presented and also got published as a fast track article in the European Heart Journal. Long-term follow-up of after ultra-thin versus conventional second-generation drug-eluting stents, a systematic review and meta-analysis of randomized controlled trial. Why this study? Contemporary second-generation thin stent DS are standard of care, but despite that, we see some higher rates of revascularization as compared. Now, why was it compared? And I'll show you. So this was less than 70 microns, ultra thin, versus more than 70, the standard second generation DS, which is 80, 84, and so on. So there was a meta-analysis from Bangalore et al. At 2018, which showed that with this ultra thin, there was reduced rates of target lesion revascularization. And if you see here, very stent related cardiovascular events and this, if you see here, this was at one year. And at 1 year, if you see here that this is bare metal stent, and these are the 2 curves. So this 5.1 is ultra thin and 8.2 is the standard. So there was a difference here. And again, target lesion failure, there was a difference. So this is what he had shown. So this study is another meta-analysis of all the randomized trial data. And what was the randomized trial data from? The stents used in the ultra-thin was Biomime, Supraflex, and Orsiro. Two of them Indian stents with less than 70 microns, almost 60 microns, versus Xience, Resolute or Endeavor, Nobori, and Biofreedom. So randomized data from here and randomized data from there. This was a review meta-analysis. Of course, the primary pre-specified primary endpoint at composite of cardiac death, target vessel myocardial infarction, or clinically driven TLR. TVF was composite of cardiac death, TVMI, and the clinically driven target vessel revascularization. Other endpoints included the components of TLF, TVF, all MIs, target vessel MI, stent thrombosis, cardiac death, and all-cause mortality. So there were 16 trials with 20,000 and odd patients with 31 months of follow-up. These are the list of trials, right, from Dissolve, BioFlow, Bioscience, Orient, the Talent trial, which was published, the BioSTEMI, and so on. So these were the trials, and this is the plot. If you see here, target lesion revascularization. Oh, again, I have to do this. So, yeah. So this was significant, target lesion failure and target vessel failure. Then if you come here, clinically driven TLR and clinically driven target vessel revascularization, this was significant. Rest of the parameters were not. So there are various iterative technologies have been trialed against conventional second generation polymer-free, bioresorbable polymer, and bioresorbable scaffolds. But this analysis demonstrates ultra-thin strut DS are associated with reduced TLF and TVF at a mean of 2.5-year follow-up. So these were the three stents, the same thing. So comments and questions. Convinced about this ultra-thin, or you require more data or randomized data? Which subset would you use? Would you use in small vessel so that the strut thickness is less and therefore there is more place for late loss? In diabetic vessels, in ISR, where you are putting a second stent so that it is a thin strut, again giving the benefit of that additional space, or in long lesions where you expect ISR? Would you avoid it in osteal lesions or calcified lesions? And do you think that we still require further DS technology, or this standard second generation DS are okay? So stop share and let us see. Dr. Carlo, what do you say about this study?
Well, I mean, first of all, some of the studies that were mentioned were randomized and did show a difference in favor of the thin strut stents, for instance. The recent one, Orsiro versus Xience, was in that direction. I'm more or less knowledgeable about the two Indian stents, but the rare cases I did outside my lab, they were very good, extremely deliverable. So I think they are interesting technology. The real issue is, can you show a large difference, a meaningful, clinically meaningful difference now that drug-eluting stents are so good, second generation drug-eluting stents? You really need to put together 25,000, a very large number, with all the limitation of a meta-analysis, of course. And I think the main issue is that in the past, the reason why you wanted very thin struts was stent thrombosis. At the time of bare metal stent, where stent thrombosis was 3–4%, I think there was a clear demonstration that a thinner strut, that at the time was 70–80, more than you know, the less than 70, had an advantage. While right now, with 0.4% in some Xience or Medtronic Resolute trial, 1 month, right, of double antiplatelet treatment, you are asking yourself how you can improve that. There is no way, basically. Still, I think this trial, and is important, it also comes from, you know, a super authoritative group, including Greg Stone, and a good publication in the European Heart Journal. They show a difference in favor, especially for target lesion revascularization. Personally, I think that I don't like the concept of one stent fits all. I think the reason probably you don't see differences in mortality is that these very thin strut stents do extremely well when you have mid-small sized vessels. When you have a left main, I'm not completely sure. I think all the second generation stents tend to have more recoil than the stents we were using 15 or 20 years ago. And there is a recently introduced stent, I don't know if it came to India, the Megaron, that goes back to 100. They have a Synergy, which is a thin strut stent, Boston, and they come back with a thick strut stent for left main. I think it's a good concept. You can't do one size fits all. That's a wrong concept. And that's probably the reason why cardiac death is unchanged, because large vessels, there is no difference, or maybe even worse in these things that stents. Smaller distal stents, you have better outcome. That's my view. I think I will be very
and also
careful.
in calcified lesions, I think you require good radial strength and for maximum stent expansion to get a good MSA.
And osteal lesion also, Carlos, osteal lesion.
Yeah, well, I think calcification is an issue that has changed dramatically after lithotripsy. You know, I think one of the drawbacks of this European bifurcation club trial on left main is that there is 0% lithotripsy in left main disease. 30–40% of them are highly calcified. So that's an old days trial. You shouldn't even look at it. There's no interest. It's all technique, right? With lithotripsy, I think that a thin strut stent probably has better probability of getting good expansion. And the problem with lithotripsy is that you create this disruption,
fractures,
greater difficulty for a stent to be fully opposed. So the lumen is a bit more rounded, but still you have these cracks that remain behind the plaque. If it's in the wrong position, a strut can be almost with nothing behind. And thin strata, I think in that setting may do better. Osteal, I don't think so. I think it's the other way around. Probably you need 6 struts.
Yeah.
Good. Ajit, your comments?
Yeah, I agree with Carlo completely. I think that we've reached a point of time that the second generation and third generation stents are very good. We use these stents according to our practice. I use more for calcific lesions, still the second generation sciences. I still use for the distal lesions or acute MI, maybe the thin strut stents. I use it for very tortuous vessels. It's your choice in that patient, what you think will go there and give you a long-term good result. So I think trying to compare all this in a meta-analysis, which is a complicated group of trials, some randomized, some non-randomized, some vis lesions, some acute MIs, and sometimes will skew. But the bottom line is death has not changed. So the big vessels outcomes have not changed, whatever stent you use. I also saw some trial recently with imaging, which made no difference between these two trials, the thin struts and the thicker struts. So it was not I can't remember what that trial was, but when you used imaging and used it well, then there was absolutely no difference between the thin struts and the not so thin struts. So ultimately it's how you deploy these stents. And, like if you have a calcific lesion and you don't debulk and you put a wrong stent, I think you're going to get into trouble. While if you do a debulking, I think, you will get a result with either stent. So I think it's beyond the stent now. And I think it's more related to lesion morphology, plaque modification, and imaging, which will make your difference to the outcomes. And I think comparing one stent versus another stent, I think it's getting too much. Most of these are, I think, industry run, and it's just trying to prove non-inferiority for one stent to get into the market. And I think it's time that we stop these trials and then go to something better.
Yeah, good. Dr. Mahesh? Do you use ultra thin stents or not in your lab?
No, not significantly, because majority of our patients, what we use is whatever third generation stents available. They do all good for us. Whatever, even it's tortuous lesion, calcific lesion, we have never used it, these ultra thin stents. So I have no personal experience, but as the meta analysis suggests, that it should probably be better, but it is difficult to understand and accept that unless you modify the plaque, modify or do a debulking, do a good bed preparation, there should be no difference, because the stents currently available are too good.
What about small vessels, Carlos and Ajit? If the vessel is small, if the strut side is smaller, don't you think conceptually that is a better way, or you?
Well, I can make one comment. We tried many. Let me give you an example of one of the stents which saw a difference in terms of how we changed our. We had one of these Zines platforms before, which moved from the classic design of what we see in Vision and Zines to Zeta and Penta. And then most of us physicians felt the original design was better. And then we moved back. And so it's not only related to struts and their thickness. It is also related to the design. Where is the link? How many links are there? Which makes differences to the whole thing. I think we should not simply say that the imprint of the metal on the wall is the only thing which makes a difference. And we see many stents which are not so strong, which may have very thin struts, may collapse when your guiding catheter hits the tip, or you pass a balloon which you have used for another vessel into this, that you get a collapse of the stent. So I think just trying to say that this is just because it's thin strut, it is better than the other strut, I think is not correct.
Good, excellent, Ajit. So we go into the last trial now, and that is TAVR for bicuspid aortic valve stenosis in low surgical risk population. So almost 50% of patients undergoing surgery for aortic stenosis, especially in the younger patients, have bicuspid aortic valve. There is scant data on outcomes of this, and many trials excluded bicuspid anatomy initially. So we are having this data on that. This is SAPIEN 3 ultra TAVRs for bicuspid or tricuspid aortic stenosis. And here we have around 7,000 bicuspid versus 6,995 tricuspid. So the annulus size was slightly bigger in the bicuspid valve, and here it is. So the bicuspid 29 millimeter size, they were more in number in the bicuspid rather than in the tricuspid. So the procedural and in-hospital outcomes were the same. Primary endpoints of death and stroke were not significant. This was 0.06 actually at 12 months in the death outcome, but not significant. And stroke was also not significant. Both were same. And re-intervention, of course, in the bicuspid at 1 year was 20%, that is 1.16 against 0.43 at 1 year in the tricuspid arm. So echocardiographic outcomes, the paravalvular regurgitation part was slightly significant in the bicuspid arm. Propensity matched overall cohort death and stroke at 1 year, as I said, was not significant. In this large national registry enrolling all consecutive patients undergoing TAVR for aortic stenosis in the US, the rates of death and stroke at 30 days and 1 year were favorable in low surgical risk patients undergoing TAVR for bicuspid aortic stenosis and similar to patients with tricuspid aortic stenosis. Our study findings suggest that TAVR may be a reasonable treatment option in carefully selected patients with bicuspid aortic stenosis who are at low surgical risk. So this is what it is. Yeah. So let us see your comments on this and whether the indications are expanding and we go further on with this. Yeah, Dr. Carlo, please.
Thank you. I mean, I think what it demonstrates is that if you have a carefully selected anatomy, you can do well, and you can have similar results than in tricuspid aortic valve stenosis. I think it's quite important if you move down from an average age, like it was in the Europe at least till now, of 80, 82 years, to younger ages. And since Sapien 3 showed an advantage of implanting TAVR over surgical aortic valve replacement with an average age of 73, I think it makes sense that we explore also the outcome when you have bicuspid aortic valve stenosis, that I remind you was an exclusion criteria for Sapien, for the partner 3 trial, okay, for the randomized trials. So the issue is how many of them have the right anatomy. And I won't go into type 0, 1, 2, whatever. It's more, do you have a heavily calcified raphe that doesn't split? If you do, if you the size of your maximal expansion safely achievable is smaller, in fact, than the aortic annulus, because the valve is doming on top and there is no way to break it, I will be a bit reluctant still to implant a valve, also because of long-term concerns in terms of incomplete asymmetrical expansion of the leaflets, both self-expanding and balloon expandable, but more the last one, which is moving at the level where you implant instead of the other one that is supraannular. I think still we should use our judgment for those lesions. So definitely an elderly patient with a bicuspid favorable anatomy, absolutely we should do it, no issue. If you have a 65 years old with a bicuspid and some question marks, there is also another question mark, which is even if we believe that our TAVR lasts as long as a surgical valve, this is 15 years. The average length of life, duration of life in Europe is around 90, a little bit more for women than men, but means you have to change the valve very likely at least once in this patient, maybe twice. And coronary access will be an issue. The leaflet that are obviously supraannular and may create problems. I think there is not just the fact is feasible or not feasible. In my view, I think we have also to be politically very careful. You can't really put the surgeon out of business because it's very risky, okay? And what the main risk is that they will start putting valves transcatheter themselves in general with poor outcome for the patients. So the way I do is not to push too much for bicuspid.
Good, excellent. Ajit, your comment?
Yeah, I agree. Again, the bicuspid is not as simple, just one bicuspid type, you know. You have severely calcified bicuspid with raphe, which don't do well. There's no calcification at all in the bicuspid, which I'm more worried about. That valve won't sit. If you have a root dilatation with the bicuspid, I'm even more worried because that valve won't seat properly. So I think there are so many anatomies in the bicuspid that you need to be very careful that whom you will select. And I think in the study also, we are not very clear, was that a selective group of patients that they did the bicuspid. I think strongly age is one of those issues which I would consider because, you know, we don't have such a big longevity in India, but still, bicuspid is very common in India as a commonest presentation of aortic stenosis. If I have a young guy who's 60 or 65, like Carlo, I call the surgeon in, but if I get a 72 or 75-year-old guy with not very good, you know, frailty and, you know, who's not going to go through surgery very well, and I think the anatomy is okay, I may fix it with the TAVR. Again, you know, I agree that coronary anatomy, accessing it. If you do it in younger patients is a problem. And I think the most important thing is not just only to listen to the patient that I want TAVR, that sort of story. I think you got to make your decision for the patient. Because many patients come and say, so I want the other thing. I have the money, or, let me do TAVR. I said, it's no good for you. That's not your patient. You go and see the surgeon, and that's the surgeon sort of will give you a better outcome. So I don't think we can decide what patients want. I think we need to be strong as clinicians and say what's good for you.
Thank you. Thank you, Ajit. So I think we come to the end of this session. We are almost 2 hours in, and special thanks and heartfelt thanks for Dr. Carlo for being with us and giving his frank opinion and his impressions about the Euro-PCR important studies which we discussed today. I'm sure there are many more other small studies, but we leave it for some other day. And I think Dr. Carlo is also happy and should come once again for some other webinar as and when he is free.
Physically now. Now we want Carlos in physical.
Yeah.
Yeah, I think, it was on behalf of CCAI International, our special thanks to Dr. Carlos. We were a little apprehensive when we heard that he's stuck in emergency, but I think emergency got over in short time. So almost 2 hours he spent with us. Of course, Dr. Ajit is our part of CCAI International, then Dr. Ravinder Rao and Dr. Balbir Singh, Dr. Mahesh, and all our national faculties, and they're the key opinion leader of our country. So we are really grateful to them for attending this. And of course, the Torrent Pharma for giving us this very important opportunity. Of course, yesterday also forgot to mention their vice president who is always behind the scene, Gagan. He's one person is always quiet. I don't know is he attending or not. Any of our educative activity, he would immediately say yes, and we are grateful to him and to Torrent Pharma. With this, I would hand over Narendra to give, formal vote of thanks from the company, Torrent. Yeah. Narendra. Yeah.
Thank you.
And before Narendra says, Carlos, we would like you to be in one of our physical conference whenever it is possible. Okay. Yeah.
Very much.
And any comments from you, Dr. Carlo, about this?
Yeah. You could just give a comment. Yeah.
Well, it's very good to do it because then you can say the truth to Indian doctors. When you are in the European setting, you have to be very careful and politically correct.
Very good. Excellent.
Yeah.
Liked it. Very good. So thanks, Dr. Carlo. I mean, it was really good and frank
opinion. Yeah.
Yeah.
Okay, Narendra.
Narendra, please.
Thank you so much, sir. And we are now towards concluding the day 2 of this wonderful program. And I must say that these 2 days we witnessed were very exciting and full of new clinical information, useful information, and presence of eminent national as well as international faculty has enabled us to gather wisdom from their experience and expertise. On behalf of Torrent Pharma, I take this opportunity to thank our esteemed faculty, Dr. Di Mario. Our heartfelt thanks for making this program so special with your presence. Thank you, Dr. Shetty. Thank you, Dr. Shah, for making this program possible through CCAI. We look forward for many more programs, such programs from CCAI. We want to participate in many more programs. Thank you so much, Dr. Fulvani. Thank you so much, Dr. Rao. Thank you so much, Dr. Mulasari. Thank you so much, Dr. Balbir Singh, for your great contribution in making this program possible and successful. And last but not the least, I am thankful to all the participants who have taken time out of their busy schedules to attend this program and make it a success. I sincerely hope your support will remain with Torrent in times to come. Thank you and goodbye.
Bye-bye. Stay safe. Take care.